should set up the test. I'll help them do it. That's
yeah.
crazy.
Okay. I'll get you in touch.
Sure.
With Terrence. Yeah. Okay. Perfect.
Is it on? Okay, thank you. Can I please ask everyone to start taking their seats so we can get started?
Just to bring you.
So if we could get started now, we have 4 talks, and we have a little bit more than an hour and a half till lunch. So if you can just hang in till then. We're going to change direction a little bit now from disease information about what's, how do doctors do things, to a little bit more of a patient-focused approach to support for patients who have neuroendocrine tumors. I'm just going to give people a minute to take their seats. And while you are speaking, or while you are sitting and getting organized, I will introduce Dr. Rachel Goodwin, who's up here on the stage with me. Dr. Goodwin is a medical oncologist from Ottawa who has a specific interest in cognitive impact of this disease on patients. And Rachel, we're looking forward to hearing what you have to say.
I'll just look for the, thank you. Oh, here we go. Yeah, so thanks so much to the organizing committee, Jackie and the organizing committee, for allowing me to speak on this. My partner in crime with regards to this project is Dr. Janice Pasica. Many of you may know her. She's a surgeon in Calgary, a net surgeon. And she actually is probably the first person that started to look at this question in net patients. So, and then her and I are moving forward a different project. So what is cognition? So it refers to the process of thinking, but more important, it's identifying the knowledge, understanding it, and perceiving it. So it's a multi-step process. Cognition has multiple domains, and when you do some reading on this, sometimes the domains have different names, but essentially they do cover off about 7 different areas that feed into cognition, and that includes attention and concentration, information processing speed, language, executive functioning, motor function, visuospatial skills, as well as memory. So lots of different aspects. So this is becoming a hot topic in cancer, cognitive changes or the treatment and the cognitive changes to the patient. And in fact, there's actually now an international task force looking at this topic, and they've put out 2 papers, one in 2012 and one in 2015. And essentially what I've listed here is some of the motherhood statements that they have through these 2 papers. And I'll review some of them now. So they do note that the cancer-related cognitive changes may be more subtle, but they are real. Okay, so that's important. So this patient does not look like an end-stage Alzheimer's patient, but absolutely the patient and the family say they're just not the same person in terms of their ability and their quickness, I guess is the way you could describe it. So more subtle, but when you start to dig into it, you do see that it's real, okay? We do have more cancer survivors now, and we know that many NET patients can live a long time, even with stage 4 disease. So it's important we start to look at these factors in particular that can impact quality of life. More data is needed. This is a real lack of information on the predictive factors and the risk factors that may set up patients for being more at risk of cognitive changes. And we have to identify if it's the cancer, the therapy, or both that are producing the cognitive changes. We need to do longitudinal studies to see what the change is over time. And we also need to look at research studies that have hypotheses, generating hypotheses, having additional test biomarkers that are trying to prove or disprove some of these hypotheses. So what are some of the facts about cognition and cancer that we know right now? We know that the early data comes from patients that had to undergo brain radiation. And of course, not surprising, they had cognitive impact changes. In general, we think this does tend to be more permanent. Then there's the chemotherapy risk factor. So many patients that have been on chemotherapy, many of you in the room maybe at one point in time, they talk about chemo fog. In general, we think there's a reversible component to that. The impact of hormone therapy, such as dropping estrogen for breast cancer patients or dropping testosterone for prostate cancer patients, The data is a little bit less robust in terms of the information, but we do believe that that probably negatively impacts. Little is known about hormone-like cancers, NET, in terms of cognition. So how does a patient describe this to you? They basically say, I'm just not feeling myself. I'm not as sharp, I'm not as crisp, I can't do the same things I used to do before. I have trouble concentrating, following instructions, my thoughts are not quite as clear, I need more structure, I need to plan more things in order for me to function. So it's not that the family's telling you, I think they're dangerous, they're not telling you that, but they're just saying they're just not the same person. And we have to look, there's some hints of this, that this has been going on. So this is the global NET survey. So this was a survey of just over 1,000 NET patients. It was a multi-country survey, and Canada actually participated quite well in this. And the main author is Dr. Simran Singh, and he's actually a NET physician as well. And if you look at this, about a third of patients on the trial were not able to continue working, okay? And of the 440 patients that said they can't work because of a medical disability, 82% said it's because of their NET disease. Now, what we don't know is was the majority of that due to cognitive issues or more just they're busy and they can't carry on their job? We don't know that, so I think we need to delve into that better. So let's shift gears to Dr. Positas Study. So she was the first one to look at the cognitive impairment associated with Carcinoid Syndrome. And her clinical experience was basically carcinoid patients had more trouble understanding, and you had to do multiple repetition of certain ideas or instructions in order for them to remember and understand what to do. So the purpose of this study was to evaluate the cognitive performance of carcinoid patients, compare them to non-cancer norms, so population norms, that's always matched for gender and for age, and also look at other cancer patients that had similar stage of disease, but they were not NET patients, okay? And that was her comparative. So we've reviewed this already, and this audience certainly is aware of carcinoid syndrome. It's mostly serotonin. About 30 to 40% of small bowel midgut tumors can have carcinoid syndrome. Mostly diarrhea and flushing are the #1 symptoms. And just a reminder again that the serotonin pathway starts with tryptophan, that's an amino acid in the body. It's converted to serotonin and then it goes into the blood and it's metabolized, and that's what we're measuring in the urine is the urine for 5-HIAA. So the functions of serotonin, they're multiple and complex. I haven't listed every one of them here, but the important ones to remember are, well, first of all, to remember what is a neurotransmitter. That's basically just a chemical messenger, okay? It's like the postman that goes and drops off the mail, okay? Please do this. So chemical messenger that regulates function. It works in the GI smooth muscle, and it allows for peristalsis, so that's movement of food through the GI system. And it works for vasoconstriction of certain blood vessels and also platelet activation. So about 90% of the serotonin is actually produced and made in the GI system, so the gastrointestinal system, and then it goes on to be stored and used in the platelets. The brain itself needs its own supply of serotonin, and 10% of the serotonin is made in the brain. So what about biomarkers? Can we use some of these tests that we do in the blood or the urine to kind of figure out what's going on with cognitive changes? Yes, we can. As you remember, we said tryptophan is the building block, and then it's used to make serotonin. So the estimate is that with small bowel NETs, they consume about 60% of the tryptophan to make serotonin, okay? So over half. And the interesting thing in the body, if you look at any biological pathway, if it has a common start point, which is tryptophan, and you drive it down one part of the pathway, so on the left side of this chart, then the other side suffers, okay? Because basically it drops the niacin, and niacin is actually been shown to be deficient in some small series of carcinoid patients as well. And outside of the cancer world, niacin deficiency is actually a disorder called pellagra, and they get a rash and dementia. So it's very interesting, the link between those two. Many years ago, when they were trying to assess what is the function of serotonin in the brain, they actually took healthy volunteers I'm convinced my 14-year-old would have probably volunteered for this because I'm convinced there's days that he does some things that are pretty ridiculous. So they actually had studies where they looked at acute tryptophan depletion in the brain and to assess the impact of what's low serotonin in the brain. And they actually did see many cognitive changes. Okay, so that was kind of proof of principle that tryptophan is very important. Okay, so let's shift gears to Dr. Positas' study. So this was the cognitive study, the first one that looked at, is there truly a difference? She took small bowel carcinoid patients with stage 4 disease. They had to have metastatic disease to the liver. She had close to 40 patients. All these patients were on somatostatin analog inhibitors, so SSAs. And you know it is either octreotide or lanreotide, a variety, and they had a variety of prior treatments, okay? So some may have had chemo, although only one patient had chemo, or some may have had targeted agents, so it was a bit of a mismatch of patients. Then there was non-NET cancer patients with liver metastatic disease. So these were colon cancer patients that were also in a similar situation where they had stage 4 disease, and 70% of those patients were on chemo. Now, importantly in the study, she did exclude patients that had other reasons for cognitive impairment, so it wasn't a confounder. They did a self-reported questionnaire, and then also they did a series of neurocognitive testing. That series usually takes about an hour and a half for a patient to do with an instructor who's putting the patient through the various tests. So we don't have to go through all of these, but this just sort of shows you the cognitive domains that they assessed and what tests they used. They used many different ones: language, executive skills, attention, concentration, all of the ones listed. So it was a good variety in terms of the test. So this is what they found. So compared to their population norms, so no cancer. So remember I said anytime you give a patient a cognitive test, you always have to compare it to what's the norm. And that's a patient without cancer. They have age and gender matched. So compared to the population norm, they found that the carcinoid patients scored lower and statistically and clinically significantly lower in 4 areas, okay? Visual memory, verbal recall, visuospatial, and executive function. Then they looked at the non-NET cancer patients, and they scored lower than their population norms, non-cancer patients, in 1 area, okay? So this was the first time we actually saw that it's probably not just cancer that gives you trouble with cognition, and maybe a different mechanism depending on what cancer you have. And certainly NET is unique to that story. When they compare the carcinoid patients to the non-NET cancer patients, so this is comparing the 2 cancer patients, once again, carcinoid patients scored lower in 2 areas, okay? So certainly interesting findings. But what does this mean for the patient? So the patient may just describe, I'm frustrated, I can't do things that I used to do before. These are the tests that they scored lower in. So what does that mean for the person potentially? Remember, we have to go back to what the patient's actually, how they're doing. It's not just the test, but it comes back to seeing the patient as well. So with executive function, it may be difficulty in doing complex tasks, visual, perceptual, understanding how I get to point A to B on a map, so trying to plan out if you're traveling, visual scanning and processing speed, the speed at which you can do things that involve multiple steps without feeling overwhelmed, okay? The memory part, recall where you put your car keys earlier in the morning, although I suppose we could all be guilty of that. Cognitive efficiency this one's very interesting because if you're trying to learn something new, how often does it take you to hear the repetition of that new thing in order to finally have it in the brain, okay? And 1 is that you're very efficient at that, but 5 means that you're not so efficient at that. And delayed verbal recall as well is, I told you this yesterday, but you don't remember, okay? So the example that the neuropsychologist gave me is, you told me you'd buy me a coffee yesterday, but now we're standing and you're not buying me a coffee, because you can't remember. So those are the kind of things that you look at. So conclusions from her study, carcinoid patients do have more cognitive difficulty when you compare them to healthy controls or other cancer patients. It's not just a consequence of having cancer. It may be a specific pathway, a specific mechanism for carcinoid patients. The exact mechanism is unknown. Dr. Pasica did a fabulous study, but unfortunately she wanted to do an extended biomarker panel, but did not have the funds to do so, because each test that we do in the blood costs money. So we're not able to tease that out, but the study did suggest that the higher the urine for 5-HIAA, the worse patients scored on the scores, the cognition scores. So that was kind of a hint. Limitations. So every study, you always have to look at the limitations so you know how you're going to improve on the next study. This was a one-time look at the patients, so it was a snapshot. So everyone was in a various spot in terms of their neuroendocrine treatment. All patients were on a somatostatin analog inhibitor, so we don't know what a baseline would be prior to starting that. And can biomarkers explain the difference? So I think I already reviewed that. So this is where myself and Janice would like to thank CNETS. They actually gave us a grant for a pilot project. So a pilot project, we're going to look at defining the tools, fine-tuning, putting about 10 patients through our proposed protocol, and I'll show you the protocol in a few minutes, just to make sure that what we're measuring it well, accurately, and we can reproduce it. And the title of this project is Patterns of Change in Cognitive Function with SSA Therapy in GI Nets with Carcinoid Syndrome. So the objective essentially is to monitor the cognitive changes over time, both before and after you go on your somatostatin analog inhibitor. We're hoping to have the funds to do a good biomarker panel so we can get some information in terms of why this is happening. And our hypotheses based on the data that I just showed you is that going on your SSA, perhaps your cognition comes up somewhat. I'm not saying it goes to normal, but it may potentially go up. And that's important because if we need to intervene, at what point do we need to intervene if there's changes over time? So our study design, it's an open label, prospective, observational, longitudinal multi-center study. So what does that mean? Everybody gets drug, okay? So if you're a carcinoid patient, of course, you're gonna be put on an SSA, either octreotide or lanreotide. And we're gonna observe over time. I'll show you the schema, and we're gonna need multiple centers to participate. So we estimate we'll probably need about 100 net patients, and we'll need about 10 for the pilot project. Stage 4 disease, grade 1 and 2, as before. We're going to allow the SSA to be by physician's choice, okay? And we're going to assess the cognition at 3 time points. So we're going to assess it at baseline, then you move on to have your 3 injections monthly, and then we reassess it again, and then 3 more injections, and we reassess it again. Takes about an hour and a half for the testing, and we're hoping to have enough money to entice people with parking, because that's like almost like winning the lottery when you get your parking paid at the various hospitals. So last slide. So why is this study important? I think it's important because we need to observe the baseline cognition and how it changes over time. So the more we know, the better we can help you. Also, do SSAs improve cognition? If they do, does a higher dose improve it more? If it doesn't, then when is the lowest point of this whole trajectory? And that's the point that we may need to intervene with certain treatments. And do non-carcinoid patients benefit? That may be a future study, right? Right now we're focusing on the carcinoid. Do biomarkers help with the mechanism? So I think I spent some time explaining why that may be important. If tryptophan is depleted and it is associated with a more significant risk of cognitive issues, if we replace that, does it help? These are the sorts of things we'll be able to look at. And should cognitive assessment be part of the care plan for all carcinoid patients? And when should we do this testing? And there's actually some exciting data coming out now in different cancer types. So breast cancer, some of the other ones that are further along in terms of the information gathering, where putting patients into a cognitive rehab program. So they actually have a planned program that involves different brain stimulation exercises. Actually, the hints are that it improves things. So especially where it can be more targeted once we have the cognitive assessment and we know what areas are having trouble. So I think I'll stop at that. And once again, cannot thank CNETS enough. We're busy at writing the protocol now. It's almost done, and this will help immensely. So thank you.
So we're going to break the rule here just a little bit. Dr. Goodwin has to leave for a family situation, and she will not be here for most of the day. So I'm going to take questions for her now, and I'm sure there will be some from the group. So thank you.
Go ahead. Yeah. Syndrome, yeah, carcinoid syndrome. Now, we're not going to be very, very strict on that definition. So we debated whether we had to have florid carcinoid syndrome, where they, basically my resident could walk in the room and say, this is a carcinoid patient, syndrome patient. With that, what we've decided is we'll do a questionnaire. If the physician believes, yes, there's some component of carcinoid with this, we'll do a questionnaire at baseline to be able to score what the symptoms are like. So retrospectively, we can look at patients with a lot of bulk of symptoms, medium, high, low, and then assess what that does with the cognition over time. Yeah.
The second part of the question, would they have to go on a different type of drug, like you mentioned the type, if they're on a different treatment plan, they'd have to change that to be part of the study?
So what we're going to do is essentially we're going to catch new patients, okay, because this is just before they go on their SSAs. But actually you bring up a good point, because if the patient or the family feels that they're struggling with cognition, you can be referred to a neurocognitive assessment already, okay? So we do have that available to us. And with a neurocognitive assessment, especially if you're already on therapy, because you won't be eligible for this study, right? We want to catch patients at baseline. That was one of the critiques, remember, in that patient where we said the task force said we need to see changes over time before and after starting a therapy. But certainly centers do have neurocognitive testing, and with that they can come up with a plan as well, okay? So this study will help us know that is this an overarching thing we have to do for everybody, because it is a significant factor. Yeah. Question at the back, yeah.
I'm just curious about the starting point of this study. What made you or Dr. Positas start with just carcinoid syndrome patients as opposed to the general medical?
Yeah, you're right. You're right. If we get enough money, everyone will be included, believe me. So we will not exclude if we have enough money. It all comes down to that. But I guess from clinical experience, it did tend to be more striking in the carcinoid syndrome patients. I'm not saying that's the truth, okay? And the mechanism actions and the biochemistry would support that. Absolutely, because we do have obviously some asks out there in terms of grants and money. If we get enough money, our original plan was to have various cohorts in the study, which is simple to add in because basically they go down the same trajectory, right? And they all patients that are G1s or grade 1s or 2s are exposed to somatostatin analogs, so we can catch them at baseline and then after. And if we have the money, yes, I think we should have a non-carcinoid syndrome group. I agree.
I don't want to go back to the Big Bang Theory or anything.
Okay, yes, thank you, because I'm not very techie in terms of that. Go ahead.
But you said the tryptophan is where it starts
Yeah.
to produce serotonin. Where does the tryptophan come from?
So it's an amino acid. So it's a protein building block, okay? So basically you get it from foods, yeah. And some amino acids are essential amino acids. You need them in your diet because your body cannot make them. Other ones are non-essential, where as long as they have the building block, they can make that particular one, okay?
The tryptophan is primarily produced in our bodies then?
Primarily, we need to eat it, right? So turkey, various foods have it, and then you eat it as a protein, and then it becomes broken down into an amino acid, which are all the little pieces that make up the protein. And then that's where the body uses that amino acid for whatever body function it needs. Okay? Good.
Thank you
Okay.
so much.
So yeah, thank you. I have to scoot away to a fundraiser for the Ottawa Hospital. I've already bought the dress and the tickets, so I can't. And I already told my husband you're going, so I'm going.
Thank you. Thanks so much.
Thank you.
Thank you so much, Dr. Goodwin. We appreciate that you were able to come and get back in